You shut everybody. No, we all do. Dr. Lowell,
Hola, yes, sir.
are we all set?
Yes, I am ready.
How do we know how many people have come in?
80 people are there.
We have to ask Tobias.
Okay.
I can see it on my screen. 80
Yeah,
participants.
We don't announce it to start with.
Okay.
Dr. Lowell?
Yes.
Are we all set? How do we know how many people have come in?
80 people are there.
You can,
We have to ask Tobias.
yes, you can see it at the bottom of the screen, but the people are still joining. So welcome to everybody that are joining. We are just giving it a few minutes.
1 minute.
Dr. Lowell, we have 1 minute to go. Are we starting on time?
Yes.
Yes. As soon as you give me the green signal, I will start.
Yeah, just 1 minute. In 1 minute's time, you start.
Okay.
I will tell you when to start.
Abhishek will tell me. I will start.
I hope we are broadcasting already.
Yeah, we are.
Broadcasting live on YouTube.
Yes, we are broadcasting on YouTube as well, Doctor.
Okay. Can you mute everybody except for Dr. Mohan Chandavarkar and Dr. Rajiv Daud right now?
Yeah.
Which is,
Yeah, I will tell Tobias
just
to do
keep it
that.
on top so that you can use this.
Dr. Rajneesh, you need to mute yourself.
Dr. Susan.
Okay, sir, it's 2 o'clock. Dr. Rajiv, you can start.
All the best to everybody.
Thank you. Thank you, Abhishek. Hello, friends. And a very good afternoon and happy Navratri to all of you. And a warm welcome to all the delegates participating in this international live webinar organized by Thane Obstetrics and Gynaecological Society Team 2021. The topic for today's webinar is postpartum hemorrhage. The organizing secretary is Dr. Datta Panandikar and moderators are Dr. Mohan Chandavarkar, Vice President 1, TOGS, and Joint Clinical Secretary Dr. Abhishek Chandavarkar. Let me take this opportunity to congratulate Dr. Abhishek Chandavarkar on his fantastic victory in IAG Managing Council elections. Now, friends, according to WHO, there are 9 million cases of PPH annually with 3% mortality rate. That means there are 50 to 90,000 deaths annually. So it's a very important cause of maternal mortality. Mind you, PPH is a very fast killer. It can kill a healthy woman within 2 hours if left unattended, and faster in a poor malnourished woman laboring in her home conditions. Now, all these maternal mortalities are preventable if we act in a synchronized, systematic way in a multidisciplinary approach. So that is the purpose of this webinar, that when the medical management has failed, what to do in a systematic and a synchronized manner. So we have invited international faculty from South Africa, Professor G. Theron, who will be talking on international innovative technique of uterine balloon tamponade. And that will be followed by power-packed panel discussion moderated by Dr. Senior Chandavarkar, Mohan Chandavarkar, and Dr. Abhishek Chandavarkar, where we will be discussing the diagnostic modalities, the various types of tamponade that are available, then beautiful videos showing the various conservative techniques, stepwise uterine devascularization, B-Lynch technique, right down to internally ligation and obstetric hysterectomy. So, starting without wasting any time, let me hand over the mic. But before that, our academic partner is SINAPI, and this webinar has been granted 1 credit point from MMC as well as ICOG. Now, with these words, I will hand over the mic to our moderator, Dr. Mohan Chandawar, to carry the proceedings further.
Good afternoon, everybody, and thank you very much, Sinapi Biomedical and Nuvios Tech, for arranging this beautiful postpartum hemorrhage webinar. I welcome everybody, a warm welcome in October to this August gathering. Although there is a physical boundary that limits our membership, the TOGS mindset is well represented by paraphrasing Gurudev Tagore's words, where the mind is without fear and the head is held high, where the ocean of knowledge is free, being led forward into ever-widening thought and action. Into that heaven of freedom, my Father, let my fellow obstetricians awake. Where the Medistaff represents our tryst with the oath, ethics, and our very being, where the O and G are in bold red symbolizing the constant threats and risks and dangers that we face in day-to-day practice, with the ever-looming omnipresent scare of obstetric bleeding.
TOGS 2021, led by our dynamic president, Dr. Rajiv Laul, and our effervescent Secretary General, Dr. Datta Panandikar, brings you Postpartum Hemorrhage, an international webinar arranged by the firm of Chandavarkar and Chandavarkar as moderators.
We OBGYNs are faced with many conundrums of all kinds of shapes in many cases, but especially when some lady is hemorrhaging. Do we conserve? Do we operate? Do we observe? Do we interfere? How much blood is required? Do we do any drills?
Are we skilled? Are we prepared? Do we have requisite knowledge to anticipate with a degree of suspicion? To answer these questions today, we have a panel of experts. Before we go into the session, President Dr. Laul has an announcement to make. I don't think Dr. Krishna Kumar has joined us yet.
Okay, done that.
We will do it after the lecture, sir.
Yeah.
May I now request Secretary General Dr. Datta Panandikar to please introduce Professor Dr. G. Thane from South Africa.
Good afternoon to all of you, friends and colleagues. It gives me immense pleasure and pride to introduce our international speaker and expert for today, Professor Gerard Thane from South Africa. He is a well-known health professional and academic from the Department of OBGYN at the University of Stellenbosch in South Africa. Professor Thane has published 104 peer-reviewed articles, and he has been a co-author in 11 books. Since 2010, he has been the editor for the Perinatal Education Program, which includes maternal care, intrapartum and postpartum HIV manuals. He has presented a whopping total of 125 papers at congresses, of which 30 are international. Professor Thane has received various national and international awards, of which the last was from the MRC Research Grant to do a case series of patients with postpartum hemorrhage due to atonic uteruses managed using the Ellavi Uterine balloon tamponade. With this, I hand over the mic to our esteemed speaker, Professor Gerard Thane. Thank you, sir.
So you can go ahead with slide sharing. You are on unmute. You're on mute, sir. You need to unmute yourself.
Thank you very much for the kind introduction. I just need to share the slides. Tobias, how do I go to slideshow?
At the bottom right, Prof, we can see your screen. Just, yes, put it in slideshow.
Yeah.
There, perfect. Thank you, Prof.
Thank you, Tobias. It's really a great privilege to be present on this webinar, especially if we take in account that we cross the Indian Ocean between South Africa and India. I have no conflict of interest. I did not receive any remuneration from Sanapi or hold any appointments with the company. We became aware of the use of uterine balloons in 2000 when Bakri published a case series of 6 women, of which 5 women had either placenta previous or low-lying placentas, and 1 a cervical pregnancy. Subsequent to that, uterine balloon tamponade became widely used, and in a literature overview which was published this year, done by Sebastian Suarez, I was a co-author to the systematic review. We found 3,653 studies, of which 644 met our initial screening criteria. 91 studies met the more stricter screening criteria. This 91 studies included 4,700 women. The 91 studies included 69 case series, 15 non-randomized trials, 6 randomized controlled trials, and 1 cluster randomized controlled trial. The overall pooled success rate was 86%, with very narrow confidence margins. Another study that is very important was published in 2018 by Sue Forkus. In South Africa, maternal deaths are notifiable by law, and every 3 years, the National Confidential Inquiry into Maternal Deaths produce a triennial report. Forkus took the 2014 to 2016 report, and that report included 624 women that died due to hemorrhage. Of those women, 128 required referral. In other words, they were delivered at a low level of care, either birthing units managed by midwives or small district hospitals. Of those 128 women, 21% died while waiting for transport, and a further 14% in transit. 35% of these women never reached their destination. Now, there are quite a variety of uterine balloons available presently that could be divided into 2 groups. The fixed volume devices, which includes the Condom uterine balloons, of which there's 2 pre-prepared kits available, and then the Bakri balloon, the Rush balloon, and the Ebb system. Then there's free flow devices that includes a makeshift glove balloon and the Ellavi uterine balloon. Both these 2 allow intrauterine pressure control. This is the example of the Condom uterine balloon. Now, the commercial uterine balloons are expensive, and most of them fill up to 500 milliliters and may not fill up the entire uterine cavity. They are closed systems. In other words, once the 500 milliliters have been inflated, the system is closed. And if used in combination with compression sutures, there are the risk of uterine necrosis, uterine myometrium necrosis. The feasibility studies published on the commercial devices included a specialist case series. And it is important to note that it takes time to fill these balloons. The Ellavi uterine balloon consists of a supply bag, a tubing with a T-valve at C, and then you can see the silicone tubing distal to the T-valve to the tip of the balloon. The shore hardness of this tubing was increased by 40% to make placement easy and feasible. Now, what differences are there between the Ellavi and other commercial devices? They are all pre-assembled and regulated devices with CE markings. marking that includes the Ellavi. However, the feasibility studies with the Ellavi was done with midwives and medical officers, non-specialists. And by lifting the supply bag, the uterine balloon fills to 750 milliliters in 45 seconds. The height of the supply bag controls the pressure. We need systolic pressure on the placental implantation site to stop bleeding. At the 2018 FIGO World Conference in Rio, I discussed this at length with Sir Saburatnam Arul Kumaran, and he concluded that that's the only way by which bleeding can be stopped, is by applying pressure on the placental implantation site, and that the pressure we need should be more or less systolic blood pressure. The Ellavi is a free flow system. It allows for uterine contraction, and fluid is then expelled from the uterine balloon back into the supply bag. The shape of the balloon prevents easy expulsion, and very, very important, it's a low-cost device.
Hi, Prof. For some reason, it's struggling to connect to YouTube. And so I will just share the video, the animation video from, oh no, wait, they're connected to YouTube. Perfect. We can continue.
No, it did connect. Thank you. Thank you. Just a few comments regarding the DVD. The placement, very, very important. the fingers should reach the beginning of the upper segment, and then the balloon is inserted. The height of the supply bag above the patient to start off with is always about 1.5 meters above the patient. That gives you 115 millimeters mercury pressure inside the uterus. And you have seen if the patient needs to be transferred, the tap is only closed. Now, using blood pressure to determine using blood pressure determines the height of the supply bag. We all know that the specific gravity of mercury is 13 times more than water. We know that the pressure we want inside the uterus is systolic blood pressure that will stop the arterial bleeding. If the patient's got a systolic blood pressure of 100 millimeters mercury and the supply bag is 1.3 meters above the patient, you will have 100 millimeters mercury pressure inside the uterus. However, it's very important to note that the supply bag must be large enough to be inflated without requiring expansion pressure. Otherwise, our formula for determining the pressure inside the uterus won't work. Now, following the initial publication in 2000 by Bakri, in 2002 and subsequently, there were quite a number of publications with a combination of compression sutures and intrauterine balloon use. And this is very important because if, say, for instance, you have applied compression sutures and the bleeding is ongoing, you can insert your uterine balloon. Or if you've inserted your uterine balloon and the bleeding is ongoing, compression sutures can be applied and then the uterine balloon reinserted. This will be successful in most cases because of the external pressure from the compression sutures and the pressure from inside with the uterine balloon. And then you won't need to resort to subsequent surgery to resolve the problem, which at this stage in the management is often dangerous because the patient has lost quite a lot of blood. Often there will be clotting deficiency. The patients already have received quite a number of units of blood. And if you can avoid, for instance, uterine artery devascularization, and also, of course, subtotal or total hysterectomy, and where available, uterine artery embolization, it is of most value. But the problem is myometrial necrosis if you use a combination. We know that necrosis is possible just by applying compression sutures. This risk increases with pressure exerted from inside by a uterine balloon. So if we use compression sutures together with the uterine balloon, it's very, very important to control the pressure inside the uterus. If you look at uterine necrosis, there's quite a number of cases published in the literature where there was necrosis with a combination of compression sutures and uterine balloons. On the picture here, you can see a patient that had a combination of a rush catheter with compression sutures, and 6 weeks later came in with an acute abdomen. On laparotomy, you can see the necrosis in the fundus of the uterus. Therefore, it is very important to control pressure if the combination is used. Now, the development of the Ellavi uterine balloon was a combined effort by myself representing my university, Stellenbosch University. We received support from the South African Medical Research Council and the Department of Science and Technology, and we also partnered with PATH. PATH is a non-governmental organization based in Seattle that promotes the manufacture of medical devices made available cheaply for low and middle income countries. And we partnered with Sinapi, which was the developer of the product. We had to consider the need of a drainage port, and the need is questionable. The drainage ports are small, the diameter usually about 2 millimeters. They are easily blocked, or if the tip of the tubing kinks, they won't drain. The placental implantation site comprises about 20% of the uterine cavity, and if the drainage port is not in proximity to the implantation site, bleeding through the port is highly unlikely. From practice, we also know if there's ongoing bleeding, it's excessive, it's obvious, it exceeds the capacity of the small drainage port. And if there's ongoing bleeding, you must act upon it. Now, the rapid filling of the uterine balloon in 45 seconds allow for a rapid assessment of whether the tamponade works. And one of the speakers in the introduction said, postpartum hemorrhage requires rapid action because it can quickly lead to the death of a woman. Now, if there's profuse bleeding and you've inserted the balloon and you filled the balloon and the bleeding is ongoing, you need to continue with the next step in your management bundle. If the bleeding is much reduced but still ongoing and it doesn't reduce within 15 minutes, you must proceed with the next step in your management bundle. If there's abdominal discomfort, as you have seen, it happens seldom, but if it happens, the supply bag is lowered halfway, the uterus gently rubbed up, and you can see the level of water in the supply bag rising, the discomfort is released, and then the supply bag can again be applied at the original height. We had to conduct a case series, which was conducted in a central and hospital and 3 district hospitals, to see whether it's feasible. Do the doctors do it correctly? Can they insert the balloon? Can they manage the pressure control? And how do they accept it? How do they find the use of this balloon? And this case series was published in 2018 in the International Journal of Gynaecology and Obstetrics and included 20 patients. And it was feasible, it was accepted, and the success rate was in line with the published success rates. Now, what is very important? The management of postpartum hemorrhage requires a management bundle. This is the management bundle following a normal vertex delivery. Now, you can see that at the bottom here in this block, one of the steps is uterine balloon tamponade. If you are if it's a midwife in a birthing unit or in a small district hospitals, the uterine balloon tamponade will happen higher up in the management bundle. But in hospitals with theaters and doctors, that's the place for your uterine balloon. Let's just look closer at that block. So if the emergency measures are applied and the bleeding is ongoing, usually the patient is taken to theater to explore for retained placental products and deep lacerations. Then once that has been done, a uterine balloon can be inserted. If the bleeding is ongoing, a laparotomy is required. Now, very, very important, the patient must be draped in the modified Lloyd-Davis position. This is like lithotomy with the hips extended by 45 degrees to allow space for the surgeon and assistant to stand. Once the abdomen is open temporarily, aortic compression can be applied. Then the surgeon must bimanually compress the uterus. Now he can observe, or she can observe, whether it has an effect of the bleeding because of the position in which the patient is draped. In other words, compress the uterus, see whether the bleeding stops. If it does reduce the bleeding, you know uterine compression sutures will be very helpful. Once those have been inserted, if it works, there's no further bleeding, problem solved. If there's still ongoing bleeding, then the uterine balloon can be inserted again. And in most cases, the bleeding will now stop. If it doesn't stop, then you have to resort to further surgical management, as we have discussed. Now, in many low and middle income countries across the globe, more women die following hemorrhage, following cesarean section, than following postpartum hemorrhage following a normal vertex delivery. The management of patient with bleeding following a cesarean section differs from the management of postpartum hemorrhage following a normal delivery. And this is the management bundle that could be used. We are now dealing with a patient that had surgery, and it requires a different approach. And again, only one of the steps in the management is the use of a uterine balloon. Let's just go to that block. So if there's ongoing bleeding following the surgery, some people may insert mattress sutures in the placental bed. However, if the bleeding is ongoing, then re-drape your patient in the modified Lloyd-Davis position. This only takes 1.5 to 2 minutes because you need to see what measures you're taking inside the abdomen, what effect it has on the bleeding. Then the surgeon can compress the uterus bimanually. If it reduces the bleeding, insert compression sutures. If the bleeding stops, problem solved. If the bleeding is ongoing, then insert a uterine balloon. If the bleeding stops, problem has been solved. If it doesn't, then you can continue with your next measurement, next steps in your management bundle that we have already discussed. Now, subsequent to the case series with doctors, we had to do a case series with midwives because of the publication by Focus showing the danger of women being referred if they have postpartum hemorrhage. So we did a feasibility study in 6 midwife obstetric units, and those 6 units together have an annual number of deliveries, close to 10,000 deliveries. And during the period of the study, 12 cases was included in the case series. The first clinical case of the case series, and I'm sure this will be very familiar to colleagues in India. It was a patient that received no antenatal care, graph 4, para 3, from a neighboring country, and she was in advanced labor at term. The admission hemoglobin concentration was 7.8 grams per deciliter. Again, I think it sounds very familiar. The midwife had to conduct the delivery, and lo and behold, there were twins.
Sorry to interrupt you, sir. We have 5 more minutes, sir.
She delivered the second twin, and then there was the placenta was delivered, and then there was torrential bleeding. The emergency measures were installed, a second drip, and the bleeding was ongoing. The midwife then inserted the Ellavi balloon, and the bleeding stopped. The patient could be transferred to the next level of care, where she received 3 units of blood and was discharged in a healthy condition 2 days later. The waiting time for the ambulance, 2 hours. The conclusion was it's feasible for the midwives to do this. They know how to fill the balloon. And in the 6 cases where the midwives did the placements, in the 8 cases, all 8 were successful with no complications. And all 12 cases in the case series had a good outcome. This case series will be published soon in the African Journal of Midwifery. Where can you find information on the Ellavi use? The theory is in a skills section on the Better Care website. You go to the Better Care website to learning programs, to women's health, intrapartum care, read free on Learning Station, and there you'll find the skills as well as the DVD. I thank you.
Excellent presentation, Professor Theron. It's very, very nice that you invented such a fantastic life-saving device. And the beauty was in the simplicity and explanatory comments that you have. And it's the video also which you all have presented is self-explanatory. So very good this thing. So can we ask a few questions, sir?
You're most welcome.
So I think it is always the case in most webinars. The first thing that everybody asks, this is from the audience, what is the cost of the device?
Yes.
I think Tobias can answer that question.
Yes, perfect. Thanks. Yeah. So just from the manufacturers, the cost of the device will be dealt with our distributor in India, because obviously some countries' custom taxes are different and also the transportations are different. So Nuvius Tech will address the costs, I'm pretty sure, after the webinar, or they did post their
Nuvius,
information.
you can put in your number and everybody can ask you the cost later on.
Yes, so I just want to mention that Dr. Abhishek was that it is a low cost and affordable device, and it is available in India currently. I will share my details on the chat, so please feel free to contact us. And a special note I also want to mention is that all the attendees, participants in this webinar will receive a special discount on the cost as well. So we will share the details with you.
Thank you very much.
The next question is also asked because we are from an Indian and from a, we always believe in ecosystem preservation. Can it be reused?
No, it cannot be reused. It must be kept sterile. And that's why if, say, for instance, it was inserted in theater and the bleeding is ongoing, it can be removed, kept sterile, laparotomy, compression sutures, and then the same balloon can be reinserted. But once it has been used or expelled, it cannot be reused because it won't be sterile.
Okay. The next question is, how long must the balloon be kept in situ, and when should we deflate it to assess the bleeding? Yeah,
if you take the international literature, it's 12 hours. We, however, suggest after 8 hours to deflate the balloon and keep the balloon, the uterine balloon, in the uterus and just observe whether there's ongoing bleeding, whether the bleeding recurs. If it doesn't happen, the balloon can be removed. That can then be repeated, but also the consensus in the international literature is that you should never go beyond 24 hours. If after 24 hours there's still ongoing bleeding on removal of the balloon, then additional measures in your management bundle is required. All cases, of course, where the uterine balloon has been placed should be covered by broad-spectrum antibiotics.
Okay, we have the next question from Dr. Kranti Vora. If a midwife or a medical officer uses it, is there a checklist for the balloon to be used?
The skill, as I've showed you, actually gives the method by which it is used. No, there isn't a checklist because it's actually very simple to use, and we really didn't find any problems with the use by medical officers or midwives. However, the training is very important. You must run training workshops, hands-on training workshops with all the staff, and that's very, very important to make sure they can do it correctly. I think that's about the key issue, is good training for the people to use the device.
We have two more questions. One is it made of latex? So should we know of latex allergy, or what is the material that is used?
The material that's used from which the balloon is manufactured. It's a silicone. The uterine tube itself, distal to the tap, is silicone, and the bag itself is also silicone. So there's no problems with latex allergies. So it's really a silicone device.
Okay, we have last question from Dr. Datta Panandikar. How can we insert the balloon after a compression suture? If it goes in easy, does it not mean that the compression suture is loose?
Yeah, the compression sutures, I think those of you that have already inserted compression sutures, you don't get the uterus smaller than about an 18-week size uterus after compression. So there's ample space to insert the uterine balloon. So that doesn't provide any problems at all. We don't advise leaving the balloon while you insert your compression sutures, because you may puncture the balloon and it may cause problems when you want to remove the balloon. So the balloon must be removed and reinserted. The other little bit of advice: following elective cesarean section with a closed cervix, the cervix should just be dilated with Hagar dilators before insertion, and that's then also quite easy to do.
Okay, one more question from Dr. Padmaja. Do we need to pack the vagina to keep the balloon in situ? And is an indwelling catheter for the bladder required?
Yeah, I think the urinary catheter very important because your patient is shocked, and in your management of shock, you need to watch the urine output. No, we don't advise packing the vagina. We want to see bleeding if it's ongoing. And if it's ongoing, you must proceed with your next steps in your management bundle. I think that's critical. The postpartum hemorrhage requires rapid action, and you don't want anything to hide the bleeding. And you may only notice that there is ongoing bleeding at a later stage.
Thank you very much for those fantastic answers, and I think most of our doubts have been cleared. Whatever doubts, the other queries you have, you can post it on the Q&A, and later on, if we have time, we shall get back to that, address to that. Thank you very much, Professor Thane, for a fantastic lecture and a fantastic interactive session. Thank you very much.
Yeah, it was a great pleasure to be with you, Mohan, and all the other colleagues.
Thank you so much. We have Dr. Rajiv Lawal has to make an announcement now. So handing over to Dr. Rajiv.
It gives me great joy and pride to announce that our own Talks member, Dr. Krishna Kumar, will be appointed as President of IAG on 31st of October. So let me congratulate Dr. Krishna Kumar, and I would like to invite Dr. Krishna Kumar to address our delegates. Over to you, Dr. Krishna Kumar.
Yeah, thank you. Can I share screen?
Yes, sir.
Thank you, Dr. Lal, the President of TOGS, Dr. Datta Panindikar, Secretary, and of course, the Chanda workers for allowing me to be present here in this wonderful webinar and a wonderful talk. And as already said, I feel extremely privileged to have colleagues and friends like you, and that has motivated me to be taking over as the president of one of the national society, first from the Thane district, and recognizing this, if you have given me great compliments. And initially,
your video has hung, sir. Dr. Krishna Kumar. Okay, till Dr. Krishna Kumar's video comes back, I would like to announce that we would like to thank the delegates. We've had about 1,500 registrations, which is a record of sorts for our webinars. We've had more than already, I can't give the exact figure right now, but we have already more than 1,000 people already logged in. So it's an amazing feat. Thank you all the delegates for making this a grand success, and we hope to give interest. The interesting videos will increase the viewership right now. Krishna Kumar, sir, we can hand over to you again.
Yeah, am I seen? Because
Yes.
Sorry, just a little glitch. So when I was taking over as the president, and 2020 is synonymous with exuberance and energy. So I had great plans to start off my year, but never did we realize that we all will be masked. And the 2020 was virus ridden. We never realized, and the fear and the risk which was exposed to endoscopic surgery was enormous. And the very fact of the endoscopic surgery was being threatened to be banished. But man proposes, as I said, man proposes, but God disposes. But we have learned new ways to learn, interact, and share. Just like what Thane Obstetrics Society in the last 6 months has done wonderful webinars and kept the whole interest much better than